I'm Cami Hurst. I'm located in Meridian. I have kind of a unique uh, profession, I guess. I'm a certified sex therapist, licensed marriage and family therapist, and my PhD is in clinical sexology. In the past, there's only been a few of us here, but that is growing. And so, as far as you wondering about your resources here in the Valley, um, there are so many talented sex therapists that are coming up for certification. So I'm excited for all of us for that. Um, but yeah, we can switch slides. Go ahead. Yeah, I've got no disclosures. I wish I did. But we're going to shoot for about 20 minutes of a didactic presentation and 20 minutes of Q&A at the end. Three things we want to cover for the CE is describing the prevalence and types of sexual problems experienced by those experiencing cancer and its treatments. Those are kind of separate. Describe care management strategies to improve the physical, emotional, and sexual well-being for couples in treatment for cancer, and identify strategies for you as the provider with the patient to address sexual concerns. You can go ahead and switch the slide. Maybe I'll just say next. That would save me some words. But before we go too far, I do always want to express my gratitude to this field. I got to walk through stage 4 lymphoma and then eventually melanoma with my dad. And it was the nurses. I loved the oncology doctors, but I will always, when I'm in a room with oncology nurses, say thank you to the way that you care for the families. So I needed you and you were there. So thank you. Um, so let's just take a minute and look at the prevalence and types of sexual problems experienced by those who are, under cancer and its treatments. We can go to the next slide. It is the third most frequently reported concern. I don't know if that strikes anyone as unusual. And people reported that it was a lot of concern. 29% did. And it was a little bit of a concern, 37%. So then we're at least 50% of patients say that at least their third biggest concern is how this is impacting them sexually. The way that it's showing up and impacting them is through some sadness and depression. Of course, the personal appearance is changing. There's stigma, there's personal relationships, and there are some real medical changes that they don't have maybe guidance through that would be helpful. We can go to the next slide. And why for all cancers? A lot of times this conversation gets stuck with breast cancer, but this is all cancers. 60% in women across all cancers and 80% in men, all cancers. So that kind of challenges who we think we need to be speaking to, right? And then if we stratify it out among different cancers, those are the percentage of men and women who said this was a big concern. Go to the next slide. You want to remember that these treatments and cancer itself are pretty global. So any surgery or radiation to the pelvis area will impact sexual functioning on any human, as well as any surgery or radiation to the brain will result in sexual difficulties. That is all of our sensory input, our emotional center, how we interpret things, but also our senses, our nerves, all has to travel up to our brain. So when we impact either two of those large centers on a human with radiation, we will have some kind of sexual impact. You can go to the next slide. So I'm going to run through quick just some of the specific concerns for the specific cancers, and then we'll go to more of some of the things about what you guys can do and offer your patients. Um, we're looking at different side effects for the treatment. So we're going to want the patient to know, hey, once we're at this stage of surgery, this is what you can expect. Then when you move on to radiation, there are different side effects you're going to experience sexually. And then if we do any immunotherapy or chemotherapy, depending on what that contains, we may have another set of sexual difficulties. And it's not just here looking at, I think we need to look beyond just appearance and changes and look at how much the body is being impacted and how this impacts their relationships and their sexual functioning. You can go to the next one. And this is the impact on a male pelvis, immediate ED. We've got these immediate things. Are we talking about what they can expect after a radical prostatectomy or what they can expect if they just have radiation? I know a lot of my clients were not told that receiving treatments here in the area. And it was heartbreaking for this couple. He was not told with the prostatectomy that he would have probably permanent ED and a completely dry orgasm. And it was traumatic for them as a couple the first time they tried to engage, not knowing what to expect, not knowing how those changes could impact them. Next slide. And then a female pelvis. Here's all the impacts we're going to have there. And it's not just body image, right? We've got some real things we can tackle too. I think sometimes when we reduce sexual functioning in cancer to body image, we make it about thinking positively. And then it's like, well, we'll just send them to the social worker. We don't have a lot we can do. But there is so much right here that we can actually do and offer the patient if we work as a team between the social worker and a physical therapist and the oncologist and the nurse. So I'm trying to kind of build this bigger picture of how we can all work together to address these global impacts for anyone experiencing cancer and the sexual impacts of its treatment. We can go to the next slide. Here, colorectal too. We don't want to think just gynecological or urological. Um, Go ahead, next slide. You're going to have these. You're going to be able to go look back, and I want to make sure we get to what you can do for your patients. Second objective, care management strategies. How can you actually help the physical, emotional, sexual well-being of these patients? Go ahead, next slide. We want the team approach. We're going to want to look at how can we help them biologically. We're going to look at how can we help them emotionally. We're going to look at how can we help them socially, right? This Survivor program is part of that social part need that you've recognized and are wanting to fill, right? So the team approach is starting to grow in our area, and it's really exciting. Go ahead, next slide. But before we ask how, do you know how to treat, or do you know someone who does know how to treat? This is kind of the condensed list of all of those sexual complaints. Do you know how to treat low libido? Do you know how to treat loss of sensation? Do you know how to treat sexual pain? And it's dozens of contributors. What about ED permanently? Atrophy, clitoral adhesions? Do you know how to assess or treat for those? What about vaginal stenosis? Are you talking to everyone who had every female pelvis has radiation about vaginal stenosis and the role of estrogen cream and preventing stenosis, right? Then we also have that loss of identity, depression, lymphedema, skin concerns, hair loss, weight gain, and orgasm difficulty. Go back one slide. That was a big question is do you know how to treat this? No, no. Even OBGYN's got a 9-hour lecture. That was all that's required in our country is a 9-hour lecture on sexual dysfunction. So before you send the referral to who you think might know, let's get real tight as a community and know who knows. Okay. Know who knows. Who are the OBs that can do this? Who are the urologists who know this? Who are the social workers, the therapists? Who are the physicians? Who are the nurse practitioners who've done the extra training? Maybe they go to Ishwish every year, right? They've done the extra training and they know who in our community to connect with to get an answer instead of an answer like, yeah, that is a common complaint. That's not an answer, you know? Okay, next slide. That's my soapbox. Um, and one major thing that I want to send you home that you can treat is when there is complaint of vulvovaginal dryness and pain, which there will be for most vulva owners if there's any kind of cancer and treatment, will be to look at how you can help biologically. And there are things you can do to help biologically. Sexual dysfunction is really common. As all of the hormones drop, sensation to the nerve endings drop. We've got a real, dryness then will reduce sensation. 93% of these patients meet the definition for sexual dysfunction. So you could diagnose that 93% of our patients once they start some kind of treatment. Baseline, 52% said they were sexually active, but 90%, or sorry, 79% of them developed a new sexual problem. So we're like, well, maybe everybody's got some sexual dysfunction. We controlled for that here. 24% of the people just stopped having sex altogether. 13% only, it was only 13% asked their doctor if there was anything we could do to change the medication. So we go from 93% having a problem to 13% of the people asking. So we might need to be doing some more offering, maybe a pamphlet or two, maybe an assessment, that they do annually, something that can bridge this gap of what we can do. You can go next slide. Interventions for this. The world and estrogen is changing quickly on all of this. And I think probably in your fields and in your offices, we've got some discussions about this too. But we do know that estrogen cream is not systemic. It is localized. It does not seem to cause a problem, but it does prevent stenosis, especially if used with dilators for 1 to 3 years after radiation is what's recommended. And you use the vaginal estrogen cream to cover the dilators to insert so that that tissue remains healthy and plump. Otherwise, we know what happens to tissue that we don't keep moisturized. And you see them in your office every day. We've got tears, we've got pain, we have infection, and it's really uncomfortable. Go ahead and switch slides. Anyway, that's something I wanted you to go back to your office after lunch today and say, okay, I know what I can do for some of, that concern. Body image is also a concern. It is worse for younger women. It's good to know the demographic of who is suffering most here. And we don't want to assume that immediate reconstruction will help. A lot of people are disappointed, and a lot of people have a loss of sensation, where maybe before reconstruction they had sensation. So there's some things to talk about without making that assumption. And also to not press that we need to get back to who we were. We are constantly aging. So getting back to a pre-cancer body is not necessarily a goal that we should be setting, but getting to our next healthiest body is probably a good goal. Go ahead and switch slides. I know we're coming up against the hour. One thing I wanted to just really define here that you as providers can start to have a mind shift around, and your patients will feel it, is if you start to think about sexual functioning, sexuality as something that all people deserve access to, or that it's part of a healthy whole human, we need to open our definition so that sexy can always include ourselves. When you're talking to your patients, have that in mind. If you yourself need to work on that, have that in mind. If we're treating sexual dysfunction, thinking sex really is only good in your young 20s, we're not going to be helping the whole person, right? So try to expand that view yourself. And in the things that you recommend, I have seen some maybe inappropriate recommendations to try to get back to sexy self that weren't very helpful. You can go to the next slide. Couples therapy is often recommended for a couple here. Next slide. Objective 3, some strategies, and we'll just go real quick through these slides if you want to go next slide. Try to send a hopeful message. Okay, this is where the relearning comes, where the reframing comes, where the education comes, where the knowledge comes, where the we didn't get this in graduate school comes. Send a hopeful message that pleasure and connection are not dependent on penetration, that an orgasm is not dependent on an erection, that an orgasm is not dependent on a prostate, and it is not dependent on ejaculation, that there is more to sex than intercourse. That sexual pleasure and connection can be developed, improved, and sustained despite any impacts of cancer and its treatments. And then know the sex therapist in your area and give them a name. It's that gap between you should look someone up and did you look someone up? No, give them a name. Next slide. Uh, a lot of things in therapy that we're doing is redefining sex with them. Next slide. Talking more about intimacy and sensuality, less about intercourse. Next slide. Opening up an idea of what is non-penetrative sex. Next slide. How do we use tools? You need these in your office and you need to be able to show people how to use them. These are not only for novelty, these are pelvic floor tools. Okay. Dilators, tools, O-nuts that control the depth of penetration are fantastic. Vibrators will wake up numb nerve endings if we want to do some PT, right? Fleshlights can be great. Also, lubrication, that is different than vaginal estrogen. Okay, lubrication does not moisturize. It just makes something slick for a while. So you need to know, do not just recommend lube, 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 lube. It's actually drying. Next step, next slide. So here's a list of validated questionnaires you can add to your assessment if you want to. Next slide. That would be really helpful. I already found you some office resources. Just have someone order these and put them in the front, okay? Next slide. Or call me and I will bring well, pay me to bring you these books and I will type up why someone should read them and we can put them in a corner in your office. All right? Just so you can point somewhere that there's some help. Next slide. But I'm happy to keep in touch. I really do like training. I really do like educating. Um, and I really do think Idaho deserves more and that we all can give it to them. So if you're looking for how do I find these people, how do I find this team you're speaking of, please look at the Association for Idaho Sexual Health Professionals. It's a nonprofit I started. Someone else in this room is actually the current president right now. Our conference is coming up in April with 8 CEs called Idaho Providers on the Front Lines, Sexual Health. But I'm done now. I hope we have time for questions. If not, I apologize.
We certainly have time for questions. Cami, thank you so much. And I appreciate kind of a nod to those resources because we definitely have people from all over the state joining. So if there's I, maybe some additional questions about local resources outside of the Treasure Valley, if anyone has other suggestions, we can use the chat for that. What questions do we have for Cami? And oh, thank you, Carrie. Let's go to you.
Just tell me about insurance and um, what resources patients have. Are they looking at out-of-pocket costs or is this covered or?
Yeah, insurance sucks. No, they do not cover marriage counseling or sex therapy. So then you're going to be looking for a therapist who's maybe going to look at it as like an adjustment disorder or that the relationship is contributing to. And then they maybe be able to bill through an individual. But most of the sex therapists I know are private practice and private pay right now for the difficult reason of working with insurance in Idaho. Uh, I think there's a lot we can do for education that is free. Um, those books would be just invaluable in the hands of anybody if they got it at the beginning of their treatment. Um, we don't currently have any group counseling or education on sexual health in St. Luke's or St. Al's or ISU, so that's something that probably could happen in for more access because it is expensive.
Hmm.
Great question. Thank you. Any other specific questions for Cami?
I have I have another one. In your conference coming up, tell me some of the topics that are covered that could be valuable for cancer providers.
Yeah. We'll be having a keynote speaker who's like the national. We're going to be talking about menopause. We're going to talk about hormones, the changes in estrogen, and recommendations that are coming out. It's multidiscipline, so it's designed for medical professionals, functional medicine, mental health professionals. We'll be having breakout groups that will be covering areas from trans care to oncology. I think Lauren and Amy maybe are going to be manning that breakout room for us. And then I'm really excited that we're going to be having an advocacy panel there to help us know what we can do to loosen up some of the uh, ways that we know we can care for our patients. Uh, yeah, so we're doing a biopsychosocial conference. It's our fifth one, and it's 8 CEs offered.
Thank you.
Cami, there was a question from Linda, but I think you just answered. Is that the same Lauren? So have you connected with Lauren Pike? Is that what I think you answered Linda's question.
Oh, I don't have the chat open.
Oh, have you connected with Lauren Pike? She's a PA at the St. Luke's Cancer Institute at the NAMPA. She's piloting a sexual health support group with NAMPA.
Yes, I love Lauren. I'm so happy she's doing what she's doing, and I'm so glad that the paths are opening for her to do what she wants to do. Yeah, it's great.
Great, thank you. You had mentioned ISWISH. Is that something that providers can use to help find other appropriate providers, patients?
Okay,
What is
ISHWISH
that?
is the International Society for Women's Sexual Health and Research. Every fall, they do a course that's the curriculum is set. It's trauma-informed pelvic exams. It's how to separate like lichen sclerosis from different vulva vag. I mean, it's 4 days of sexual health medicine that we all need. They do that every fall in Scottsdale, Arizona. And then every February, they have their conference for 2 days, which is always, in a different place with different topics. But if you serve women and you want to help them with sexual health concerns, that is a world you should plunge into. Uh, yeah.
Great. Cami, also, sorry, anyone else has questions, please chime in. I'm wondering, you mentioned the association. Is there representation statewide? What does that look like
Um,
with your colleagues around Idaho?
yeah, we're trying to get more. Right now, it's really Treasure Valley led. We've got the president, though, is in McCall, so we're reaching, we're starting to grow. And we've got some interest in Eastern Idaho. But yeah, we're 5 years in and hoping to grow and stretch.
Oh, great. If there are any other questions, we'll just take a minute, make sure we don't move too quickly. Um, well, thank you. If there are questions, you can put that in the chat. We'll continue to monitor that. Cami, thank you so much for the information and truly an important part of the whole team to survive for our survivors. So thank you for your
Yeah, I just
information.
want to let everyone know, like, I really would come train your office. I really would come talk. I really would. I really do feel passionately about the role that you providers can do to help people. So I really would.
Well, Cami, thank you. Fantastic.